think. Okay. So today we're just finishing up with our Doppler, mainly so how do we use this while we're scanning, making sure that we're using it accurately. When we learned about the properties of Doppler last week, it was more of what is our machine doing to create that reflection, right? And how do we analyze that reflection? Today it's more so how do I optimize that and make it the most accurate that I possibly can. So we learned about all of those different angles last week. We learned about cosine last week, right? We don't want anything coming in perpendicular because the cosine of 0 is 0, so we're not going to be getting accurate velocity representation when we're using our Doppler. So when we have different degrees of incidence, if we remember this from kind of the mid-semester mark, we want to be coming in at different approaches so that we can line everything up as well as possible. So our normal incidence, when we're using Doppler, we have to have an angle other than 90 degrees, so other than perpendicular, for our color to appear. So this is just our color Doppler here, not our pulse wave Doppler yet. The color will never appear when the sound beam and the vessel are perpendicular to each other. So if we look at this top example up here, this is saying that we want, really? This is saying that we want our color to be 100% perpendicular or 90 degrees to that vessel. And see how no color is filling that in? We don't want that. So we need to have some type of oblique incidence to get our color represented in that vessel. So we want to be aware of where our sound beam is coming from, and then also the steering of the box that we are using. So when we're giving it some type of angulation, which way are we angling it? That also matters because that's going to determine the direction that it's represented to us in. So we need to be aware, are we steering our color box to the left or are we steering it to the right? So now both of these examples on the bottom, you can see that those color boxes are being steered in opposite directions, and it's representing flow appearing to be traveling in two different directions when that may not necessarily be the case. My little drawings. So like we said, we want to have some type of angulation to our color Doppler and our pulse wave Doppler when we're looking at a vessel. So we need that oblique incidence. So this is going to be those same concepts that we learned about last week. When we're perpendicular, no color is going to fill it. So even if we have our vessel on an angle, if the color box angle and the sound source angle is still 90 degrees to the angle of that vessel, we're still not going to get anything in it. So if you look at that top example, on the previous slide, our vessel went straight across the screen, but on this vessel, it's on an angle, right? But now we're telling our color box, okay, so my vessel is on an angle, I want that. My color box is on and I'm steering it, but I'm still 90 degrees to that vessel angulation. So I'm still not getting any color flow. So this is why our, this is why all of those angles matter. So the angle of the vessel and the steering of the color box need to be appropriate with each other. So angles less than 90 degrees are going to produce our color flow. Anything less than perpendicular or even greater than perpendicular, but it's going to determine the color direction. That's what we're shooting for here. So the smaller the angle between the vessel and the color box, the better. So if you look at that middle box, I'm not going to draw on these slides because my little pen is kind of going crazy. But if you look at that middle box, you see how our vessel is on an angle, right? We see our color box is a perfect square. There's no steering of that color box. But because of that angle of the vessel, it's not a 90-degree relationship. So we are still going to get some color coming into that vessel. But the smaller that angle difference between the vessel and the color box, the more accurate that color representation is going to be. So on that bottom example, do you see how the color box is steering? Right? So you see how now we've decreased that angle difference between the vessel and the color box, and we're getting a much more accurate representation of that color filling the vessel. Okay, so two examples here. Again, if we look at our top little transducer, this represents our sound source. So we're not steering our color box at all. We don't have any angulation to our sound source or our sound wave as it's traveling through. So that color box is coming in perfectly straight. And our vessel has a little bit of an angle to it. So the color box and the vessel are not perpendicular. So we know we're going to get some type of representation, but we're getting pretty minimal flow in there, right? The vessel's not filling nice and beautifully how we want it to. We could be making it look like there's some type of pathology or blockage in that vessel. So we want to make sure that we are decreasing that angle difference between the color box and the vessel. And that would be this image here. So we kept the same angulation of our vessel, but now we are steering and we're creating that oblique incidence on a less degree of angulation between the vessel and the color box. So it's filling nice and beautifully. Okay, so now we're getting more into some of our artifacts here. We will get to the actual artifacts in a few slides, but we talked about this last week as well. Our color Doppler gain is really important. We don't want it set too high. We also don't want it set too low. Both of those can create false pathology. So we need to have it set appropriately, and we need to make sure all of our factors and our principles are lined up so that we're getting a true representation of what's going on in the vessel. So if our angles are correct, we want to look for our color Doppler gain settings. So if we know we have angulation to the vessel, we know our color box angulation is appropriate to that vessel position, but we're still not getting it to fill appropriately, or we're getting all of this artifact and this noise, then we need to look at our color Doppler settings and that gain setting in particular and adjust that one accordingly. So this top picture, that's representing a Doppler gain setting too low. We have a nice relationship between the vessel and the color box, but we're still not getting that vessel filling in beautifully. And then that representation on the bottom there is our gain setting too high. So those we just want to be aware of. We can create pathology in both of those scenarios. Same thing with our Doppler gain setting. So now we have a beautiful color Doppler. We're ready to pulse wave Doppler that vessel, and our settings are all over the place, right? We may be getting aliasing. We already know how to adjust for aliasing, right? We talked about that last week. But we also may be getting spectral broadening, and spectral broadening can represent pathology, or it can represent our Doppler gain settings, our spectral Doppler gain being set too high. So we need to be aware of that as well. Again, the first things that we're doing, we're checking our relationship between the vessel and the color box. We're checking our color gain, and now we're checking our pulsed wave gain, or our spectral Doppler gain. So inappropriate spectral Doppler gain settings can cause the appearance of turbulent flow, or that spectral broadening that we learned about. And we want to make sure that our controls are set so that we're getting a clear spectral window when we're Dopplering a vessel. So if we look at this picture, and we look at the spectral analysis here, right here, see how we're barely getting a waveform? We can't even really see it. We can't really even differentiate where the peak velocity would be. This is with our spectral Doppler gain settings too low, right? So we would want to turn that up a little bit so we can see it more clearly and a little bit stronger. So this is appropriate right here. Even right here, I would say this is still appropriate, but that could be a little bright for some radiologists. And now we're getting into the range of, you know, an inappropriately set spectral Doppler gain. See how we're getting all of these echoes filling in here. We're getting all of this artifact in the spectral analysis. We don't want any of that. And then see how our waveform gets really, really bright, almost to the point where we, again, can't see that peak velocity. Same thing when that setting is set too low. So we're looking for that happy medium right in the middle there, where we're getting a strong, clear waveform, but we're not getting any extra noise or artifact creating spectral broadening. Okay, so aliasing, we've already talked about this quite a bit. I'm just going to move right past that. We all feel pretty good with aliasing? Okay. And our wall filter. So we mentioned this very, very briefly, if you guys remember, but what this does when you are using your color Doppler in particular, but also your pulse wave Doppler, the machine is going to eliminate all of those low frequency Doppler shifts. So any Doppler frequency that's coming in, whether it be color or pulse wave Doppler, if it's too low to be clinically relevant, it's just going to erase it. It's not going to process it. It's not going to analyze it. We're just going to get rid of it if it's too low. So this is when we have our slow flow being reduced, and it's also going to have sensitivity to flow being reduced. So sometimes it's not appropriate to use a wall filter. If you're looking for a renal artery, we know that those arcuate arteries in that renal cortex are so, so small. We don't want to have a low sensitivity to those vessels. We want to have a high sensitivity to those vessels. We want to make sure that we can fully evaluate them. And just because they may be moving slower than, say, the aorta is, doesn't mean that that's not clinically relevant. So we don't want to use a wall filter in those scenarios where we need to be sensitive to those low flows or those slow flows and those lower velocities. So it's not going to affect our high velocities. So carotids would be appropriate to use a wall filter for because those are really high velocities to begin with. But more so that renal artery stenosis, doing any type of Doppler in the abdomen where the flows are a little bit slower, you don't really want to be using too much of a wall filter. But any peripheral artery, so your arterial legs, your carotids, you can use a wall filter for. And if we see here on the side, this is kind of showing what it would do to our waveforms if we were using a wall filter while we were doing pulse wave Doppler. So if you look at your low wall filter setting right in the middle, it kind of gets rid of some of this slower information closer to our baseline, right? Because the velocities as it goes above our baseline get higher and higher, faster and faster. And we're saying that our wall filter is going to erase some of those lower frequency signals. So it's going to kind of erase some of this information here. Now we don't really want a really high wall filter because if we have a high wall filter setting, we're getting rid of all of this information here. We don't want that, right? That's not a true analysis of an artery that we would be using this for. And if we look at what it would look like for just our color Doppler, we're getting rid of some of that surrounding information. So this would be a higher wall filter setting here. See how we kind of got rid of some of these hepatic vessels? Our hepatic veins are going to have a slower velocity than our main portal vein, right? So they're going to be erased when we're using a wall filter setting. Okay, so this would be another example of where wall filter would be appropriate. So we're looking at a carotid here, and we could decrease our gain, our color Doppler gain. We could increase our scale, right? But we could also use a wall filter to get rid of all of these lower frequencies. Now my color thing's not even working. Right over here. So all of this low frequency information right here, we would get rid of if we had a wall filter setting on. Okay, so moving into our artifacts. So artifacts are really going to be any type of error in imaging. And the main cause of artifacts is when our system or the body part that we're looking at, really the system, the transducer, or the patient, it occurs from a violation of assumptions. So our assumptions are the normal parameters that we're used to, right? Those acoustic parameters, those sound parameters that we learned in those first 2 lectures of the semester. All of those things that we learn, sound travels in a straight line, right? It has to oscillate, something has to vibrate. When one of those things doesn't happen, it's going to create an artifact. So there are different types of artifacts that are mainly created from either a violation of those principles, or there's some type of operator error, or there's some type of physics error, or equipment malfunction, right? So our machine's not functioning properly. That cause is going to result in different types of errors in imaging. So the types that we commonly see, we're seeing something that's not real. We're not seeing something on the image that we should be seeing. There's an incorrect shape or size to something that we're seeing. There's an incorrect position to where something should be located, or we're getting incorrect brightness. So those are the main categories of artifacts that we can create, or rather that can occur. So these are those basic assumptions that we just talked about. Sound travels in a straight line. It travels directly to a reflector or a boundary and back. The standard speed of sound in soft tissue travels at 1,540 meters per second. Reflections arise from the structure positioning in the beam's main axis. So when we learned about axial and lateral resolution, right? What's that smallest amount of space between 2 structures that can still create 2 different appearances on our picture? We also assume that our imaging plane is very thin because of the way that our scan lines are produced from the machine, right? That's kind of a standard assumption in terms of manufacturing. And then the strength of a reflection is related to the characteristics of the tissue that are creating that reflection. So what we're trying to image makes its own appearance on the system itself. So those are our basic assumptions. So when something doesn't go according to plan, in agreement with those assumptions, that's when we're getting these errors in imaging. So reverberation, this is one of the most common ultrasound artifacts. We see this every single day on pretty much any exam that we're performing. It's kind of an operator error, but it's also a physical error as well. So it's caused by the bouncing of sound waves between two strong reflectors positioned parallel to the ultrasound's main axis or main beam. So it places too many reflections on the image, and then the first and second reflections are going to be real, but the rest following posterior to that, those are not going to be real reflectors. So basically those first two boundaries that we see on our image are going to represent real strong reflectors, so real strong boundaries, and then everything posterior to those first two bright lines are going to be fake, right? So think of like an echo, right? Your voice creates that original sound, and then it hits off of an actual other real structure, but then any other echo that you hear after that is not real, right? So your first two reflections are going to be real, everything else is going to be artifact. So the characteristics of reverberation, pretty straightforward. We're going to see multiple equally spaced echogenic lines. They're going to be parallel to the sound beam's main axis, and we're going to see it at increasing depth. So we're going to see these lines posterior to each other. So our red arrows are representing where those reverberation artifacts are coming in, and you can see that they continue to travel down posterior into our image. They're going to be equally spaced. That's an important thing to remember with this. And then you'll also see that these are sometimes referenced as Venetian blinds. So if you've ever been like in a really old, like a grandma's house, and they have like those like really old dusty blinds, that's kind of the appearance that it gives on our display. Also, Comet Tail, we're very familiar with this one, right? So this is something that, again, we're seeing very commonly. We're seeing this a lot of times to either prove that something is pathology or not. So we're using this for our gallbladder. We're using this for our kidney stones. We're kind of relying on Comet Tail to actually help us make a diagnosis. So yes, it's an error in imaging. It's an artifact, but it's helpful. It's a helpful artifact. It's going to be caused by closely spaced reverberations, so similar physical concept to actual reverberations, but they're spaced really close together. They're very focal in where they're occurring. So they're most likely to appear when the reflector surfaces are in a medium with a very high propagation speed. It's going to result in a solid hyperechoic line that travels directly downward from that original source. So whatever is causing that Comet Tail artifact, you're going to see it directly posterior to it. And the characteristics, we're going to see single long hyperechoic echoes parallel again to the sound beam's main axis. So we're going to see, if you look very closely, we see a line, a line, a line, right, all traveling posterior to that original source. And then same thing, a little bit more obvious in this second picture, you can see really how posterior that Comet Tail travels. Not really something that we're going to see in a gallbladder or a kidney, but this is the pleural space for a thoracentesis. Next, we have shadowing. Again, another really helpful artifact, but it is in fact an artifact. So this is going to be caused by excessive attenuation in tissues that are more dense than the posterior structure. It's going to result in hypoechoic or anechoic regions extending directly downward or posterior from that original source that's creating this artifact. Characteristics of this, it's going to be either hypoechoic or anechoic. It's going to be located directly beneath whatever that high attenuation structure is that's causing it. And it's going to cause us to not be able to visualize anything posterior to that structure, right, if we remember that. But again, it's helpful in us diagnosing actual pathology. So it's going to be unrelated to the speed of the tissue. Comet Tail artifact, reverberation, that has to do with the speed in the tissue. Shadowing, this has to do with attenuation of the tissue, right? So how much of that sound beam is being absorbed. And then shadowing may provide information to help characterize that tissue. So this is going to help us aid in that diagnosis. Also, not even really just for like a stone. If we have really dense fatty liver, yes, that liver is going to appear very echogenic, but it gets more and more dense, right? So our sound beam is going to be attenuated more through that fatty liver. So that posterior right lobe of that liver is going to have shadowing. So that also helps in the diagnosis of more of a physiologic pathology instead of just like a stone or something. Next, we have edge shadow. Again, another helpful type of artifact. helpful in diagnosis, but this is going to be caused by the sound beam refraction at the edge of that curved reflector. So if we remember when we learned about refraction, they have that little picture in your textbook of the pen or the pencil in the cup of water. When you're looking at it, it looks like it's heading in one direction, but then when you look at it in the water, it's heading in another direction. So that's going to be the same concept here. So as that sound beam hits that rounded edge of whatever our boundary is, it creates that refraction at that edge, creating this edge shadowing. So the beam diverges at that curve, resulting in a drop in that strength of that sound beam. That decreased intensity is what is causing that edge shadowing. So we're not getting any useful reflections along that pathway of where the curve is. It's going to result in hypoechoic region extending downward from the edge of that curved surface. So pretty self-explanatory in those pictures, both of the gallbladder. It's kind of really the only rounded structure that we look at. So it's really the only thing that we're going to see creating any type of edge shadowing, unless we're looking at a huge liver cyst or, a kidney cyst. It's really the only natural organ that would create edge shadowing. It's going to be hypoechoic or anechoic in those regions and extending right down from the edges of the curved structure. Again, we're not really going to be able to visualize any information in that pathway that it has, so that can be a little bit detrimental, but we can kind of work around some of those things, right? We can very easily sweep through our gallbladder to make sure we're visualizing all of that tissue as well as we should. Next, we have enhancement. So again, we've learned all about this. This is going to be caused by the inappropriate number of reflectors that are too bright due to low attenuation characteristics. So basically, our sound wave is not being attenuated enough as it's traveling through these. So these are going to be posterior to our cysts, posterior to our gallbladder. We know that sound travels faster through fluid, so we're going to get that enhancement posterior to a tissue that sound travels easiest or easier through. It's going to result in a hyperechoic region posterior to that low attenuation structure. So we're going to see that region or that pathway of really hyperechoic tissue directly posterior to that. It's the result of too little attenuation. So pretty straightforward. We should be pretty used to looking at enhancement at this point. Next, we have focal enhancement. So this is a little bit different. This is not going to be directly posterior. It's not going to be parallel with the sound beam source. It's actually going to be a band that goes directly across our screen horizontally. So it's known as focal banding because of that. And it's caused by abnormally strong reflections that are positioned at the focus. So this is something that we could create essentially depending on where we're putting our focus at. It's going to result in that side-to-side band or region of increased brightness traveling horizontally across our screen. It's also going to have the same appearance as incorrect TGC settings. So you know how sometimes you guys want to just adjust one TGC button at a time? Like, no, you can't do that because this is an artifact that you could potentially mimic when you're doing that. So you want to smooth out your TGC curves and you want to make sure that your focus is being positioned at the correct location. So this is actually going to be caused by increased intensity at the focus. So depending on what structure we're looking at, depending on our other settings, if we have our focus set in an inappropriate location, we could be sending more of that sound beam's energy to that level, and that's why that horizontal piece of our screen is appearing more hyperechoic or more enhanced. Next, we have our mirror image. So we haven't learned about this quite yet. We kind of talked about mirror when we were learning about our Doppler last week, but mirror image or mirror artifact is mainly referencing something when you're just doing your regular 2D grayscale imaging, and it's when you're actually creating the same structure on, it's like a mirror, like when you look in a mirror, right? When you flip it. So if you were to look in your mirror, your left hand does not appear as your left hand, it shows up on the other side, right? So this is going to be that same concept. So when you have a sound reflecting off of a really strong reflector and it's redirected towards a second structure. So if we look at our example here, we have our liver and we have that liver capsule, right? We have that edge of the liver, and that's a really strong, dense, fibrous tissue. So that's why it's going to appear more hyperechoic in that region, right? Because it's protecting all of that tissue. So when we have this mass that's located really close to that strong reflector here, it's going to create a mirror image on the opposite side of it. So this is the first thing that's going to draw our eye to this image. But if you also look, it's actually reflecting more of that liver tissue on the opposite side as well. So this pathology, this mass, this hemangioma probably, is the first thing that's drawing our attention because it's so close to that boundary and it's pretty obvious. But if you look further, it's actually mirror image of all of that liver tissue. Do you guys see the liver on the opposite edge of it? Okay. So characteristics of this, we're going to see a second copy of the true reflector. The artifact appears deeper than the true reflector. It's bouncing itself more posterior. The mirror lies on a straight line between the artifact and the transducer, and the true reflector and artifacts are going to be located at equal distances. So you're always going to see it more posterior. So that's how you can kind of tell what the true structure is. Sometimes you could see two masses in the actual organ, so you don't even have the boundary of the organ to help you. You're trying to determine, are these two different things, or is this the same thing, one on top of the other? Am I getting mirror artifact? So look at your surroundings, see if any other tissue is being projected as a mirror artifact as well, and then that can kind of help you determine, is this really two findings, or am I just looking at one pathology with a mirror copy? Next, we have crosstalk. We learned about this last week, so it's that mirror artifact, but when we're using it for Doppler, we know how to adjust for that. We're turning our gain down. We are increasing our scale. So we're going to carry on. Speed errors. So these are a little bit harder for us to identify. And it makes our job a lot harder because sometimes you're like, why does this picture not look right? Like, why can't I get this clear border? Why can't I determine if this is a discrete pathology or if this is normal tissue? And that's probably going to be from some type of speed error artifact. So these are caused when we have a second wave that propagates through a piece of tissue at a speed other than the speed that normally should be traveling in soft tissue. So it could be traveling too fast or too slow. If it is traveling slower than it should, our reflectors are going to appear deeper than what we're looking at. So we're going to see something kind of abnormal posterior to where we're looking. If it's traveling faster than it should be, we're going to see that reflected above where we're trying to look. So for this example here, we're looking at transverse left lobe of the liver, right? So we're looking in this region here, and our sound source has already traveled through all of this tissue. But then we're kind of questioning, like, what's going on in this area here? Like, is this my border right here? Is this tissue right here? Like, what is this? Is this liver tissue or is that peritoneal tissue? We can't really tell because we don't know what this is. Is this our border or not? And this is being reflected posterior to that left lobe of tissue. So this means that that second sound wave was traveling too slow through that liver. And that's why we're getting this kind of discrete, bizarre area posterior to where we want to be looking. These are commonly going to appear as a step off edge. So if you look at your picture, if you were to imagine that none of those blue arrows were there, you have this line here. Can you guys see my little arrow on the screen? It's just easier than using the pencil. You have this line here, and then you have a dip down, and then you have this line here. So that dip, right, where you're like, is that the border? But if it is the border, why is it not continuous? Like, why does it have that edge to it? It looks like a little step. That's how we can say, is there some speed error going on in this region? So you're looking for that discontinuation of two reflectors. Next, we have lobes. So we kind of talked about these a little bit when we learned about resolution. Again, kind of hard for us to differentiate. We could just be saying, is there, sludge in this particular organ? Is there incorrect TGC settings? So lobes, kind of like those speed artifacts, are going to be hard for us to exactly pinpoint. But lobe artifacts are going to appear when the sound energy is transmitted in a direction other than along that main axis. So this is kind of going back to that resolution, right? Axial and lateral. How closely together can we position two structures, either side by side or one in front of the other, and still create a clinically useful picture? So it's going to result in a second copy of that true reflector, but it's going to be positioned right by its side. We do have two different types of lobes that we have to be aware of. We have side lobes and grating lobes. Those side lobes are going to be created usually by mechanical transducers. So we're not using those too often. We're mainly using array transducers. So that's going to be more of our grating lobe artifact. And they're both going to appear the same way. It all just depends on what transducer you're using. That would determine if it's side lobe versus grating lobe. So if you get a question on the registry that says, you're using a particular transducer and you see a picture that kind of looks like this, you have to say, okay, well, what kind of transducer is that? Is that a mechanical transducer or is that an array transducer? And then which artifact is going to come from that, right? So it's kind of a two-part question. So we can reduce lobes, whether it be side lobe or grating lobe, either by subdicing or apodization. Your textbook has more information on it. This isn't something that we do. We're not looking for the subdicing button on the machine, right? We probably have never heard a tech say, oh, apodize that image. It's not something that we're doing, but it is something that you do need to be aware of for your registry. And you do have to be aware of seeing that image and saying that something's wrong with it, right? And then how can I fix that image? What tools do I know? Can I adjust for that? Next, we have our refraction. So yes, it's important on the physical level, like just the physics properties of knowing what refraction is, but it also can create an actual visualized artifact on our screen. So if we remember this, it's when our sound beam is transmitting, it hits a boundary, either it's going to be reflected or it's going to continue traveling. If it continues traveling but at a different angle, that's when we know we're at refraction, right? So that's transmission with a bend. So this is when that sound beam is now traveling in a different direction than it originally was. So our sound wave is going to strike that boundary obliquely, and the media on either side of that boundary is going to have different propagation speeds, causing that change in direction. So the characteristics, that second copy of the true reflector is going to be positioned side by side or at the same depth. So if we look at this example here, this would probably really confuse you guys if you saw this while you were scanning out a clinical, because you would be saying, okay, if I'm doing my transverse aorta, you're probably saying, okay, well, which one's my IVC and which one's my aorta, right? They both look the same. They're probably both pulsating at you, but this is your IVC, and you have to figure out which one of these is your aorta. So somebody doesn't have a duplicate aorta. At least I've never heard of anyone having a duplicate aorta. So you have to determine, okay, well, what's going on with this? Why am I seeing two arteries side by side in this example? Slice thickness, we kind of talked about this as well. Not something that we're really adjusting for either, but you do need to be aware of it for your registry. This occurs when the reflectors outside of that sound beam's main axis are being displayed on our image. So our sound beam is traveling in, and we're saying that we want to process all information coming from this one pathway. So kind of think about, like, if you're driving on a main road and you really only care about what's going on that road, right? You're paying attention to the car in front of you, you're paying attention to the line in the road, but then you also kind of get some information from the sidewalk, right? Is anyone trying to cross the sidewalk? Is anyone walking on the sidewalk? Is there a bike on the sidewalk? So you don't want to have to think about those things, but sometimes those things will come into that main road on the highway, right? Or whatever road you're traveling on. So we don't really want that. We don't really want any of that information that's coming from the periphery of that sound beam's main axis to be displayed on our image. And when that does happen, that's the slice thickness artifact. So the sound beams are going to be three-dimensional and thick, but these reflectors exist and are positioned outside of that beam, and they appear as though they are coming from within the beam. So it's going to result in anechoic structures appearing filled in or giving us some type of noise in that anechoic structure. So this example that they're using here on the side, this is a bladder, right? We know we want that to be anechoic, but we also know that sometimes we can get debris in the bladder, right? We can get blood in the bladder. So we want to be able to say, okay, is this echogenicity in the bladder, is this real, or am I getting some type of artifact because it's an anechoic structure? So you just need to be aware of figuring out what's real versus what is artifact. So we're adjusting our gain, we're adjusting our TGC. We're having our patient stand up, walk around, roll, see if we can get any of that to move. If it moves, it's probably real, right? If it stays in that same position when the patient rolls, it's probably going to be some type of image artifact. And lastly, our lateral and axial resolution. Again, we learned all about this. Lateral resolution, how closely together can two structures be positioned and appear as two separate things on our display screen side by side. And axial resolution, how closely positioned one in front of the other can we still represent two different images. So when we're getting those reflectors kind of off of that axis, depending on if it is either side by side or one in front of the other, that's going to be abnormal or poor lateral and axial resolution. So nothing new there, and that kind of relates to that slice thickness as well. And then in your textbook, you guys are responsible for just refreshing on noise, line density, right? We just learned all about that. Same thing with T-frame, clutter as well. We kind of mentioned that briefly last week, and range ambiguity. So just make sure you're refreshing those topics as well. They just kind of jump back to them in this chapter. So we already kind of talked about them in previous chapters. But if you're doing any of the questions at the back of the book, you'll see some questions about these topics as well. So nothing too crazy. Stop recording.